Very good morning to everyone who have joined us here today on breakfast at UMHealth this morning. So today we'll be listening to two speakers, one from biomedical imaging and one from the ophthalmology department. So to start it off, I'd like to introduce our first speaker today, Dr. Tang Li Kuo. He's currently a senior lecturer at the Department of Biomedical Imaging, a medical physics lecturer. And he was previously the head of biomedical engineering at the UMMC for 5 years. He has co-authored over 40 papers in peer-reviewed scientific journals. His research interests include medical imaging, image processing, and artificial intelligence. To date, he has been an active investigator in multiple research projects, totaling over 700K in grants and with 150K as principal investigator. So today we'd like to invite Dr. Tan to share with us his work on AI in medical imaging. Dr. Tan, over to you.
Thanks, Dr. Jeannie, for the kind introduction. So as mentioned this morning, I'm just going to have a brief talk about artificial intelligence, AI, but specifically from the field that I'm interested in, which is in medical imaging. So I think by now, everyone's already familiar. AI, artificial intelligence, kind of like exploded in popularity, starting roughly around 2017. And this is mainly thanks to what we call big data, and which is just literally what it sounds like, a lot of data, especially in the medical field, and what they call deep learning, which is a specific AI technique, which if we have time, I'll get into a bit later. So it's reached to the point that things like powerful AI tools like ChatGPT have entered the public conscious. I think even if you haven't used it, you've definitely been saturated by news about it by now. So what actually do we mean by AI then? So one way you can define it is in AI, you have a computer that does a task, and that's nothing new. But instead of just repeating the task blindly, it starts to make decisions based on the input without needing for a human to oversee every single decision inside that. But where exactly a normal computer program stops and starts being AI is still a little bit fuzzy because it depends how complicated the decision making is. So for example, you have a traffic light, it repeats from red to green, green to red. But what happens if you add things like presence sensors? What happens if you have queue sensors? What happens if you have not just one traffic light, but entire cities worth of traffic light that integrates together with traffic flow management? Where exactly does the AI start? And so it can be a little bit fuzzy. And the reason I'm mentioning this here is because some of the examples I use later might not fit the usual idea of AI. So let's go to AI in medical imaging. And I'm going to be talking about 4 different categories here, but I'll focus on 2 of them. So one of the things I want to mention is that AI, due to the, especially modern AI, due to how it's structured, it really is very flexible. And you can use it in many different places. For example, in workflow management, scan ordering, patient scheduling, so on. Image acquisition, when we actually take the image and we want to improve the image on that sense. Image analysis, we have the image already. Now we want to extract information about the image. QC and dosimetry, we want to improve the quality of the overall workflow and the image acquisition. Inside there, dosimetry is checking patient doses. And in this case, many of these tasks will overlap. But today, I'm mainly going to focus on these 2, image acquisition and image analysis. So let's start with the imaging workflow management. And this is just a quick slide. So the idea here is, can AI assist with scan ordering? For example, inside the radiology department, because it serves the entire hospital inside there, so it gets inundated with requests for scans. So sometimes these scans are justified, not justified. It requires a human to kind of like be the gatekeeper inside there. And sometimes these scans which are ordered may not be suitable. For example, another modality might be more appropriate in particular instances. Or what is the urgency inside there? Can an AI become the gatekeeper rather than a human? Patient screening. Are they pregnant? Implants, allergies, other risk factors inside there. Once again, this is usually human-based. Can an AI help? Patient staff scheduling and optimization, scheduling for holidays and leave, special expertise, prep time, inpatient, outpatient, all these kind of things. there's usually a person trying to get a grasp on the entire scheduling of the whole department with so many people. Can an AI step in and help to do this kind of automatic scheduling? Report management, adaptive reporting templates. We talked about ChatGPT. This is a particular family of what we call large language models, which are very good at handling text. So inside here, so can we use these similar type of LLMs to summarize patients' medical history instead of having to search through all of them inside there? So these are some examples of how AI might be able to help, not so much in the imaging part, but in the workflow management part. Now let's move to the next one, AI and image acquisition. And here we talked about how the AI can help to enable improvements in quality, time, and dose. By dose here, I'm referring to the X-ray radiation, the amount of radiation that's delivered to the patient side here. And typically, you want to minimize the amount of radiation because there is an element of risk or harm that can come inside. Now, so that you see improvements in quality, time, and dose, they're usually all related to each other, as in one will affect the other. Now, AI and image acquisition can come from two basic aspects. One in the image reconstruction and restoration, and once again, these tasks can overlap. So in image reconstruction, you get the raw acquisition data. So for example, in CT, that would be the sinogram or an MRI case space. If you're not familiar with that, I'll just show you an example later. And from there, you can produce a higher quality output image with less artifacts inside there. Or for restoration, you might given the final reconstructed output image. For example, this would be the typical CT image or the ultrasound image you're used to. How you process it to improve the quality or to reduce artifacts. So let's give an example. So if you're not familiar with CT, computer tomography, what actually happens is this. So this represents the patient. I know it looks a little weird, but just imagine this is one cut of the patient. Now the CT doesn't actually see this image. What the CT does is it sends X-rays through the image, and then this is the actual raw output that you get. So you can think of it like this. This is the original, this is the patient body, or what we call the tissue property map. This is what we want, but we can't get it. Instead, the image process tries to capture that, and inevitably there's going to be noise inside there, and what you get is the resulting acquired data over here. And there's going to be artifacts and noise simply due to the nature of the scan. So what happens after that in image reconstruction is that this raw data, or what we call the sinogram, it gets filtered through this process called filtered back projection. And they try to reconstruct to get the original information out back again, which is the tissue property map of the patient we want, right? So this has been the traditional reconstruction method for a long, long time, and it's still actually used even today. Now, there are other methods. So for example, there's something called iterative reconstruction, which you start from that previous filtered back projection, but instead of just using it like that, now you use physics to actually simulate the projection data, and you compare it and you adjust and you repeat until you're satisfied. So what I mean is that they pretend they know this is the patient like this. When I say tissue property map, that means this is soft tissue, this is air, this is maybe bone, and so on. And if that is true, then by the physics, it will simulate the whole process, simulate the sinogram, simulate the whole thing. And the difference here is they can add in things like noise, things like artifacts until the simulated version matches the final version. Right? So it feels like we've gone a whole big loop just to get to the same place. But the advantage is after you've done it and you're convinced the simulation is correct, then you can remove the unwanted parts of the simulation, which in this case would be the artifacts and the noise. Yeah, result in an image that's much cleaner, much nicer inside that. So it's very useful, it's very powerful, this method, but it's very slow. And of course, there's a danger in that this physics model that you're using to do the simulation, if it's wrong, then you're going to get the wrong image. You're going to get a wrong image output inside that. Now we come to the AI part. So deep learning reconstruction, it also takes the raw data inside here, and similarly to the iterative reconstruction, it takes the raw data and it transforms that into the final image inside here. But it doesn't transform it based on a physics model. It doesn't transform it based on geometry or any particular physical math inside there. Rather, it's in to out. And the resulting the results of that is that it can actually produce very good images inside that. It's faster than doing the iterative reconstruction that we said just now. Simpler to design because you don't need to worry about all these physics models. And the image quality tends to be very good. Having said that, there's a big danger here, which is that the deep learning part is what is kind of like a black box. And so you can never be totally sure what you're going to get outside. And if the input becomes unexpected, then the output can also be unexpected. There's an aside here, but given time, I will skip through this. Just a brief talk about how the deep learning works. But the main thing I want to emphasize here is, because of the nature of deep learning, what it is an entire box full of random numbers that slowly get tweaked as you, what we call, train the deep learning network. And so if you want to do deep learning, what really matters is getting these good training or testing data. That's 80% of the work. And in many cases, if you've ever gone into this, you may have heard of these deep learning architectures like ResNet, like DenseNet, all these kind of things. They don't actually matter too much. Most of them do a reasonable job. What matters is this and your ability to define the nature of the problem. Meaning you got to program into the deep learning network what is considered a good output, right? So meaning if your output is an image and you want it to have good image quality, then you have to define it in a mathematical way what you mean by good image. Okay? So let's go back to here. Deep learning reconstruction inside there, and I'll repeat. What you have here is the input, and what you have here is the output. So that tells you that gives you a clue of how the deep learning network is trained for image reconstruction. What it basically is you provide it with tons of example raw images, these sinograms, and you provide it with tons of example images of good reconstructions. For example, iterative reconstruction. So you tell it, figure it out. Figure out how to go from here to here. And deep learning can figure it out. But often the network is just too complex. It becomes like a black box. And yes, the output it gets is very good, but it's very hard to get the deep learning network to kind of like explain or interpret how it's actually going from here to here. Okay, given that, let's look at some actual examples. I'll go share some example research, but I'll just mention right now, most of these are mine. So here's one example of image reconstruction in MRI. So here we have the raw data, but it's purposely undersampled, meaning that to properly get the image, let's say you need to repeat the scan 100 times, but now it's undersampled, so you only repeat it about 33 times, for example. Okay? So here's the gold standard data. Here's a fully sampled one. Here's the input where it's undersampled. Sorry, the difference are rather subtle inside here. You really have to zoom inside to see. And here is the output of the deep learning one. So meaning, given this input, they learn how to reconstruct it at much better image quality. So the architecture that was used here, the deep learning architecture, is what they call an encoder-decoder, or so-called U-shaped network inside there. The loss function is what we mean by the definition of what is considered a good output. In this case, they use something called mean squared error, which is easier than it sounds. It just means take the image that you get compared to the image that you expect to get, and you literally just subtract them, square them, and you get the average. And the training data was only about 180 subjects. And voila, you managed to get a pretty good result. Next example, in image reconstruction or restoration, this time for CT. So this one's interesting in that it's processed at the raw data level, at the sinogram. But instead of reconstructing the whole image, they're focused on artifact removal. So what they call a metal artifact. So meaning, if a patient goes for a CT scan, but they happen to have an embedded metal implant, for example, that actually causes artifacts inside the resulting reconstructed image. And you can see that inside the original raw image sinogram. So this particular deep learning network removes that artifact before moving to regular reconstruction. And so here, architecture, fully convolutional network, loss function, similar was mean squared error. And in this case, it was just 200 CT data. Now let's go to image restoration. Now this one is not at the raw data level. This is at the image level, the image level. So the image level meaning the input is an is a reconstructed image already. So it's just a typical image that you would already be seeing inside your your image viewers, for example. So in this case, it's for denoising of low dose acquisitions. So meaning acquisition that's purposely using very little radiation for the sake of the patient. And so that results in usually images that are very noisy. But then they want to use deep learning to try to improve it to reduce the noise. So in this case, interestingly, what they did was they use a scan which typically would be multi-frame. So meaning they have to capture, this is the heart, by the way. So they capture the heart at multiple frames inside there. And for the training data, they extract one frame as the input. But for the gold standard data, they try to match a lot of frames and they average them together. So they become as if it was a high dose acquisition. And they say this is the gold standard inside there, what they call a multi-frame averaged image. And then they tell the deep learning network, figure out how to get from here to here. And so this is the resulting image. So this was the original. This is the deep learning output. Notice the much less noise inside there. So the architecture here, once again, fully convolutional. Loss function slightly different, mean absolute error. Training data, about 100 subjects. So quick summary that we have so far. For AI image reconstruction and restoration, very powerful capabilities, often much faster than existing methods. For example, the iterative reconstruction one I mentioned just now. And there's no need for a detailed physics-based model. So in a way, it's actually much simpler. All you really need is the input raw data. It can be the raw data or the reconstructed image. You have your desired output, and you need to define a quantitative measure of performance or success. Sometimes we call that the loss function. And these improvements that come from the deep learning reconstruction and restoration, you can spend it on either improved image quality or shorter scan times or lower dose or maybe even both. But the deep learning network, we often call it a black box. And because a black box means we're never completely sure what the network is actually learning to do. So meaning that it has so many parameters inside there. So a network can actually learn to, because you don't know how you're actually teaching it. So you can actually memorize certain patterns and you end up just pasting them inside the matching areas that decides, okay, I think I know what a heart looks like. I see this as a heart. I'm going to just stick a template heart inside that. And you don't know. And this particular problematic, if any subsequent diagnosis is only made on the enhanced image without checking the original just as a sanity check. So as an example, this was a couple of years ago when deep learning was still somewhat new. This is not in medicine. This was in general imaging, a technique called super resolution. It's a form of image sharpening. And if you have any high-end smartphone cameras, a lot of them do this now. So meaning if you zoom, you get a low resolution image. So they actually use a form of deep learning to improve the resolution inside that. So one notorious example was the example image that a photographer used, and he sent it through a deep learning network. And when it came out, he got this. That kind of looks like a ghostly image inside there, but the internet went around and they identified this was actually Ryan Gosling, which is the actor inside Barbie. What happened was that the neural network somehow decided to memorize his face and noticed that the input image somehow matched him and just pasted inside that. And no one knows why it decided to do that. It just did it. Okay, so that was AI for image reconstruction or restoration. Now we move to AI image analysis. So here we're going to look at two things: segmentation, quantification, as well as detection and diagnosis. And in this case, once again, the tasks can overlap. So we look at this one first. Segmentation. That basically means delineating objects of interest inside here. So in this case, let's say this is a cardiac MRI. You want to delineate where the left ventricle is because you want to measure the blood volume. So in this case, you have gold standard delineations. Your input is a image, architecture, encoder regression, loss function, mean squared error, training data, 100 subjects. You can see how it works. Then for CT multi-organ segmentation, same thing except for multiple organs in this case right now. So input images, output masks. This is the liver, this is the lung, and so on. So architecture, encoder, decoder, loss function, mean square error plus DICE, which is a different imaging metric. 90 subjects inside there. Detection diagnosis, ultrasound. So this is slightly different, in which case they were training a network to search for, detect what we call pleural effusion. So despite what the picture here shows, how they trained the network was the input is just an image, but the output is just a yes and a no. Is there pleural effusion? Yes. Is there pleural effusion? No, inside there. So the architecture encoded regression plus encoded classification, loss function mean squared plus ordinal cross entropy, and about 70 subjects. And here's one famous one, detection diagnosis for chest x-rays. So automated diagnosis, chest x-ray in, diagnosis out. So there's no delineation or segmentation here. It just says, oh, detected edema, oh, detected pneumonia inside there. Now, the nice thing about this particular example is that this is actually a rather famous data set called Checkspert, and it's available for public use. So meaning you too can download this along with all the labels and try your hand at deep learning yourself. So the original paper, they used the encoder classification architecture, loss function, mass binary cross entropy, training data, 200,000 images. So very much into the deep big data realm. So quick summary about AI image segmentation, quantification, detection, and diagnosis. Okay, segmentation and quantification, good performance, flexible, and as a bonus, is viewed as a human assist tool rather than a human replacement. So there are very little controversies of adoption. So people like it, it's useful, it got immediate adoption. Now for automated detection and diagnosis, it's powerful but very controversial. In particular, it's a very sensitive topic because if you still remember early in the days, there was a lot of hype about this is going to take over radiologists' jobs. And in particular, some of the deep learning networks which try to do diagnosis without any kind of localization, which means without saying where the particular diagnosis is referring to, is particularly problematic because it's difficult to interpret how the AI actually is making its decision. So there's some famous stories about how you train an AI and it makes a decision, and it turns out later it's making a decision on a totally wrong thing inside the image. Which brings us to one particular important topic that we have now, which is because deep learning is a black box, there's a lot of research going into trying to make the deep learning networks interpretable, or how to understand how it actually makes the decision. Or at the very least, convince yourself by the output. It's usually not so important if the output is dense. So what I mean by dense is the output is not just one label, but actually some kind of a lot of information from the output. So for example, segmentation is dense because from the entire image, it tells you exactly what it considers the organ. So in one glance, you can tell, all right, yeah, I am pretty convinced it's correct. Although when it gets it wrong, it can still be puzzling why it got it wrong, because sometimes it's obvious and yet it goes wrong. But it's particularly important for what happens when you have deep learning networks which try to do diagnosis with no localization. And there are some techniques that try to improve it. So for example, this GradCam method, where they try to retrospectively go back and it says, okay, the AI made this decision, it made this decision based on these particular locations. Which brings to another side topic, which is anomaly detection. Most of the examples I talked about is under a particular field called supervised learning, which means you give the AI the data and you give the data and you tell the AI exactly what the correct answer should be, right? So the problem is what happens when it's tested on disease not in the training set. So for example, that Checkspert data I just mentioned, a lot of data, 200,000, but it was released in 2019, right before COVID-19, which means if you train it on the Checkspert data and you pass it a COVID-19 patient, it will not be able to categorize it correctly. So we probably need to have some form of anomaly detection rather than a specific supervised learning inside there, for it to be more generalizable to go into the future. But so far, this is not very common in medical imaging. Okay, now the last part, which is very quick, AI and QC and dosimetry. This is rather specific, so I won't go too much, but it's very related to the previous topics as well. And it really just looks at how we can improve QC of the machines as well as how to do better, estimate the patient's dose better inside there. I'll just skip this one. So here's a quick summary of today's one. AI medical imaging. Basically, 4 methods inside we can look at: workflow management, image acquisition, image analysis, QC, and dosimetry. Hopefully, the message here is that AI is flexible, modern AI is flexible, and it is possible to integrate it in many, many different aspects in medical imaging, not just in the imaging itself. Now, having said that, obviously, a lot of the interest is on the image itself. And so some key take-home messages: beware of the black box output of the AI. And there's a lot of emphasis on how we can make the AI more interpretable. Right? Opportunity and pitfalls are plenty. And with that, thank you very much.
Thank you, Dr. Tan, for that very excellent presentation. And so we have a few questions here. So from Prof. Yu Kun Chan, is database peculiar to institutions or shared as a global database for the deep learning by a computer? Not exactly if you get that question.
Sorry, can you repeat the question again?
You can also see in the Q&A. So is database peculiar to institution or shared as a global database? So I presume it's just is asking about the source of that database. Is it?
Oh, okay. There's no. It really depends on the institutions. So for example, there are some global organizations that are multi-institute. They work together and they share the data into one common database. There's also the very famous there's very famous I suddenly forgot its name, but inside UK there's the biobank where there's actually they actually consolidate a lot of the data from all their national health service inside there. So that's another example of a huge multi-center database. Just now, the Checkspert, that comes from one center, but there's actually a partner, another partner hospital that also did the same thing and they came out together. So if you want to double the database size, you can also get the partner database inside here. So anyway, bottom line is, it depends. That one has less to do with the AI specifics and more to do with the working relationships.
Okay, thanks, Dr. Next question. Maybe you can comment on this. Does biomedical imaging department at UMMC, that's our department, uses AI in clinical services?
So this one, let me clarify right now. I probably should have mentioned this right from the start, but I'm not a radiologist. So I better let a radiologist answer this one. Having said that, I do know that they already use some of these AIs inside there. For example, they have tried some AIs for doing mammographic screening before, and like I mentioned, the moment we think of AI, we jump straight to the diagnostic part. But AI gets used in many other places. For example, the cardiac one where you have to quantify the left ventricle blood volume inside there. AI segmentation tools are already available and we're using them already. And because they're useful and they're not controversial, you kind of forget they're AI.
Okay, thanks, Sultan. Last question. Can a radiologist plagiarize some of the information from the AI analysis and redo it to claim the new output as totally his own?
Yes, of course they can. So you can't
stop. It's a bit like ChatGPT, right?
Yeah, I assume the question here is, can a human radiologist pretend that the AI output is their own diagnosis? Yes, they definitely can. Yeah. There's nothing stopping anyone from doing something like that. Right? Now, having said that, of course, it comes down to whether you trust the AI output. And at the end of the day, you can move this to become a medical legal question as well. Because at the end of the day, that medical diagnosis, So far, in terms of medical
responsibility.
legal, someone's name still has to be there to take responsibility.
Yeah.
So if you place your name there, even if you used AI tools to do it, you're still responsible.
Yeah. Yeah. Agree. So there's still a big gap in the legal, the legal regulation of the use of AI. I mean, around the world as well. At the moment, I think the clinicians or the radiologists or any other clinician who uses still takes responsibility for the use of the whatever tool that they use. Right. So thank you, Dr. Tan. I think
Wait, there got one more question, I think.
one more. Oh.
Yeah.
Um.
Yeah, so just a quick one. I'm looking at it right now. The question is, I learned in some hospitals overseas, they use commercial AI analysis tools to help interpret the images, for example, chest x-rays. Is this kind of tool helpful for us? And I'll say this depends on the individual. So some tools some radiologists definitely will find them useful, not just as to, okay, put it this way. Some institutions have decided they're using it for triage. So meaning there's an inundation of scans that come in. The AI helps to say that, I picked up some serious cases in this. You might want to look at them first. So that's just for triage. Some institutions have found them useful as second readers. So humans still goes through it, but the AI also goes through it in parallel. And and if they differ in their opinion in any way, then you go back and have a second look inside that. But I don't think there's any institution so far that's kind of like totally tried to replace or taken the human out of the loop. This is so far, it's really as an assist tool. So yeah, I'm sure there's going to be usefulness inside there.
Right. Thanks, Dr. Tang. So I think due to the time constraint, we will thank Dr. Tang for his excellent thought and answering all the questions. Any further information that you would like to clarify, feel free to contact Dr. Tang by email and discuss that. So I'll let